to introduce a very novel concept, a very novel surgery which is being done for the first time in India. It is my privilege to tell you all that we've done the first 12 cases in PD Hinduja over the last couple of years, and we have been able to introduce this novel surgery, being the first center in Asia to do this. So, osseointegration is an innovative way to rehabilitate amputees. All the patients, of course, have been consented. Now, everybody knows that amputees in general are normally rehabilitated with sockets. सबने Jaipur foot के बारे में तो सुना ही होगा that everybody who gets an amputation gets a Jaipur foot. But the problem with these sockets are multifold, uncomfortable, taking time to don and doff, heavy, require replacement frequently, never stable, bulky, and often ugly. So what really happens is this is how you end up walking with a socket. And see, this gentleman is 47-year-old. He does not have any comorbidities, and he has to struggle throughout the day, sifting through his chair, sifting through his walking style. Similarly, this gentleman could never use a socket. And there is this other lady who's trying to walk on a socket, but this lady has an AFO, which is an ankle foot drop on the other side, wearing an AFO. She's bilaterally deaf, has multiple sclerosis. So walking like this is the biggest task for her. So you can imagine how difficult it is to rehabilitate with a socket. A limb like this is very difficult to fit a socket into. Similarly, you can see that the bone is pointed right in the front, and a socket is very difficult to put on. Even in this kind of a patient, even in this kind of a stump. So what is the solution? The solution is osseointegration. Now, osseointegration was introduced by a gentleman called Ricard Brennemark, and I have very, very high regards for Ricard. Very, very senior to me, but I am very happy to say that he's a very good friend of mine. He has developed this surgery from his father, who's actually the father of osseointegration in dental surgery. And he developed what is known as a screw device, which is being used to mobilize amputees and done osseointegration in amputees from 1996. Ricard has done over 500 patients and very, very successful stories. But there are certain problems with his protocol in terms of rehabilitation being a minimum of 6 months and 2 surgeries being minimum a year apart. So these were the drawbacks associated with the screw type of osseointegration. So hence, being a joint replacement surgeon, being a hip and knee reconstruction surgeon, I said press fit implantation was what was in order. So my professor, who is from Sydney, Dr. Munjid Al-Muderis, actually we developed a technology where we developed this implant along with a gentleman from Germany. And this implant was based on press fit technology. We further innovated with this implant with a German company. And we are making this implant now very much in India, thereby reducing the costs significantly. And so this has got a very beautiful cobalt chrome structure, which actually fits and integrates with the bone, which is essentially the premium system of osseointegration. Essentially made up of a cobalt chrome alloy and stainless steel, and now titanium. Consists of a titanium niobium coating. So this is what integrates with the bone, and you can see how, like popcorn kernels, the bone actually grows into this mesh structure, and this implant becomes a part of their bone structure. So you'll understand as I go along as to how this procedure is done. But before I go on to that, really need to tell you that as general practitioners, you might be getting a lot of patients with who are amputees. They may be diabetic, they may not be diabetic. They may be struggling with their socket prosthesis. So this is a very big point that I want to convey in today's meeting, that one should actually watch out for people who are suffering from these socket problems, and then send across these patients to us for an eligibility. So what is very important is this screen. I would like everybody to note, because patients who require osseointegrations are socket-related discomforts, non-smokers. They understand all risks and complications, means they are very well aware of themselves. The relative contraindications are peripheral vascular disease, radiation exposure, or smoking. I have recently done a type 2 diabetic who was an amputee for 35 years, and I haven't had any infections. So it's no more a contraindication being a diabetic or losing a limb due to diabetes. The 4 risk factors which I have been able to identify over the last 9 years that I've been doing this procedure are smoking, alcohol, BMI, and gender. Obviously, keeping all these in mind, we have to stringently work out whether a patient is eligible for osseointegration. Sushilji did mention that I did a PhD. One of the articles mentioned on my PhD essentially was the safety of an osseointegrated implant. Because whenever I tell people that I'm placing an implant in the bone and I'm making a hole in the skin to externalize the implant, people say it'll get infection. But no, that's not the case. The first 86 patients that we did, that is the first 91 implants, we followed them up for almost 3 years, that is 34 months. And we've graded the infection in various different ways. One will notice that mild infection and irritation, although common, about 20-25%, but easily treatable with oral antibiotics. Severe infections resulting in septic loosening are rare, in fact, as low as 0.5%. And that also in the last 4 years, we've eliminated with various things that we do in surgery. The clinic obviously includes the role of a prosthetist, includes my role, includes the role of a physiotherapist, does include the role of other patients as well. And peer-to-peer advising is very important in order to share their experience. And this is how we end up achieving this. And we've started this clinic in PD Hinduja Khar now. So what happens is once the patient's eligible and once they are confirmed to have had the surgery, they undergo a full routine testing protocol, including gait analysis and functional assessments. And this is how we measure as to how much they can walk. See with how much difficulty this lady is walking. This lady is actually wearing a socket prosthesis and she's finding it very difficult to walk. We also do something called a timed up and go. This is a bilateral amputee who visited me from New Zealand. We have to get a psychological assessment because they need to be aware of what they are doing. We have to intricately plan the surgery for them. Hence, custom implants are designed based on exactly their bone structure and CT scans. And then their bone density scans are done. The first thing that I want everybody to understand that bone density reduces in an amputee, not because the patient is amputated, but because the patient can't weight bear on that bone. So essentially, the aim of osseointegration is to increase this bone density by allowing the patient to weight bear on that. So normally done in a single stage or in 2 stages. I have started doing this in a single stage. Now you can see that there is a small video representation whereby you'll understand exactly what the whole procedure is and how it's being done. So essentially involves a press fit implant being placed in the bone in the first stage. So the stump is amputated. The stump is revised in this fashion. An implant is actually then placed into this bone, utilizing joint replacement and press fit technology. There has been a large improvement in the implant design over the last 9 years, whereby we moved on from cobalt chrome macrostructures to titanium plasma sprays, which is still not available in India, but we are trying to get the machine into India and trying to manufacture it completely in India, where partly our processes are done in Germany now. Once this implant is placed, this is describing as stage 2, but now we do it all in one stage. So that is all in a matter of 3 hours, the patient has this kind of a stump structure and the patient's external parts are applied and the artificial leg is applied to this structure. Just giving you a lowdown of what is done during the procedure does not include only bony stuff. It includes soft tissue management, whereby the entire soft tissue is revamped in order to close down the bone implant interface, in order to close down the soft tissue bone interface, so that there is no ascent or ascent of infection. These patients complain a lot about neuromas and pain. So you see, in almost all my patients, we excise a massive neuroma. This is how the stump would look at the end of it with a mouth. And this is how the stump would look at the end of it. Post-operatively, the patients are discharged like any other total knee replacement or a total hip replacement. I'm glad Dr. Alabadia talked about pain. We do use adductor canal blocks regularly. If the amputation is higher than the adductor canal, then there is ketamine, which is used, and ephemeral blocks, which are used, which are sensory. Post-op care is actually 2 weeks onwards. Patients shower normally and clean it like they clean their teeth on a daily basis. This is how the patient is completely aligned after an osseointegration surgery. And these are how the x-rays look. So you can see now the patients, now that the surgery has been done, the patient starts static loading, that is 5 to 7 days post-surgery. And you can see he bears 20 kilos. The amount of weight is progressively increased. And ultimately, they're allowed to walk with 2 crutches. And then they go through locked knee, strengthening balance, early grade training, and parallel bars. This is the first time this gentleman has actually walked on his leg and is feeling the ground over the last 16 years. Definitively, we fit them in parallel bars, fit them into technology using with the help of Autobock and computer navigation. Once done, they actually walk in this particular fashion. Because they've never really walked with complete weight on this stump after them being amputated, this is the biggest achievement on our end in order to rehabilitate these amputees well. This is just recapitulating the same gentleman who I showed you earlier and the same lady with multiple sclerosis. You can see that, I'm sorry about the video being a little gnarly, but you can see how she's walking. And she's walking unaided, without the lurch, without the gait. Being bilaterally deaf, cochlear implants is a major challenge. But I'm quite glad that this has been possible within 2 days. And she actually traveled to India in the COVID times, and we did her at PD Hinduja. So obviously, there's no socket needed, no skin irritation. Permanent contact with support surface is no longer required. No pain while sitting. So there's no toilet seats broken. No inflammation, bruises, or hematomas. It's a very simple and a secure attachment which happens within 2 seconds. So patients are like absolutely normal, wearing a sock and removing a sock. The biggest advantages of osseointegration is what you can see here, that they can actually start feeling the grass, carpet, tile, and uneven ground, which is completely impossible with a normal socket prosthesis. And this is what we call as osseoperception. So this gentleman, as you can see, is actually placing his leg on a rubber mat, and he can actually feel the response from the rubber mat. And this is the first time he's being done. So this is the gentleman who traveled from Pakistan to get this surgery done. This is commonly what patients are able to do after a surgery like this. They become absolutely normal. This gentleman was a spray painter for aeroplanes, and he fell down from the wing and broke his leg. And I'm happy to tell you that he's actually opened a custom-made garage within a year of having had this surgery. And he's able to make an earning for his family, which is the biggest thing possible. So the aim is to return to work and recreation. The total number of implantations which have been done by me in Asia and in India are about 26. And this has been done over the last 3 years, because the first time I introduced this surgery was in 2018 in PD Hinduja. Everybody will talk about costs. The costs obviously are minimized because now we're manufacturing this implant in India. They'll be custom manufactured. And as you can see by this comparative study that I did in Sydney, that there is a massive difference in lowering of cost in spite of having had a major surgery like osseointegration, with compared to a socket prosthesis.